and for Dr. Ahmed for the marvelous organization of this magnificent meeting. I'm going to talk a little bit about pediatric emergencies, vascular emergencies. Aortic are among the most important of these emergencies. I have nothing to disclose. This is clear to you. Aneurysms are the main hot topic of our talk today. And the other two emergencies that may happen in pediatrics as well as adults, the trauma and the presence of acute ischemia. You know all the challenges. It is the growth of the child, making any conduit not suitable for a long time. And there is always an issue of the choice of the suitable conduit. And the small size of the vessels makes them always technically challenging. As a result of the rarity of the diseases, we don't have any consensus about the treatment options. So treatment strategy is always not very clear due to small numbers and heterogeneity of data. Aneurysms, as you all know, are very rare in children. The etiology could be mycotic, vasculitis, connective tissue disorders, rheumatic, congenital. All of these causes are rare but well known. And the management as in adults is supposed to be between open surgery and endovascular means, but I can surely tell you that in pediatrics, still open surgery plays the major role in the treatment for the aneurysms. I will go with you through few cases to demonstrate the different treatment options. The first one here is a 7-year-old boy who underwent repair for an aortic coarctation. And look what he had on the left side here. He had an aneurysm, an infective aneurysm at the site of his thoracic repair. And on the right side, you can see even a filling defect inside the aorta. It's actually a fungal infection as proven by the blood culture. And it was repaired primarily by the cardiothoracic surgeon. And again, there is a recurrence of infection. Not only that, on the right side, you can see embolization, which resulted in mycotic aneurysms at the aortic bifurcation. This was repaired by a tailored graft. It's a 6mm Dacron graft, which is tailored to be fitting well to the size of his aorta and his iliacs. And the follow-up CT can be seen on the right side. 10 years later, at the age of 17 years, the child started to complain of significant intermittent claudication. And his duplex scanning showed the presence of stenosis. Clearly, they are corresponding to the Dacron graft, which didn't grow as much as the growth of the child. Actually, it grew a little bit, but not to the same extent. So it's time for definitive reconstruction using 16 by 8mm Dacron graft. At the beginning, I thought it will be a very difficult procedure, but actually just sewing the graft to virgin areas made it very easy, and it wasn't like the normal when we face a redo case, because the child has grown, so the new virgin areas are actually like very, very big, and you can work comfortably in these areas. Second case is an 11-year-old girl, and she had again an infrarenal mycotic aneurysm repaired using a superficial femoral vein. For this girl here, we could manage to use an autogenous graft, and her size was quite possible to do something like that, and she went fine afterwards. The next case is a 3-month infant, and he presented with abdominal fullness with shock. And unfortunately, I don't have an intraoperative image, but so I drew this illustration here to show you that whole of his abdomen was occupied by this huge aneurysm. Urgent explorations was done, hemodynamic instability was present, and the iliacs were extremely small, like 2 or 3 millimeters. And unfortunately, I couldn't do anything apart from ligation, but eventually the infant died. Last case, an 11-year-old child presented to Aboris Children's Hospital with hypertension. While he was investigated, this aneurysm here at the level of the SMA was found. It was 35 by 6 millimeter. And we started a workup for this kid. We were actually confused what is the etiology. So it was like a multidisciplinary approach to manage his disease. Rheumatology consultations, they answered us that this could be Takayasu arthritis or Behçet's disease, and pediatric nephrology consultation was done trying to control his blood pressure, and anesthesia assessment was done to see how are we going to deal with this aneurysms. But eventually, while we were doing this, a few days later, we suddenly found abdominal pain, distension, hemoglobin drop, tachycardia, and an urgent CT angio was performed. On the left side, you have the old CT we just saw, and on the right side, you can see the similar cut at the same level. You can notice now that the size of the aneurysm is 66 millimeter, and you can notice even the rupture beside the right kidney. So we had to rush to the OR for surgery and to control the bleeding. And can I have my video played? It's not working spontaneously. So you can see how large it is and the rupture. I made an illustration on the right side here to show you the aorta, the celiac trunk, and just adjacent to the celiac trunk, you can find the aneurysm after its new size. And both renal arteries were again arising from the lower part of the aneurysm. So after clamping and proximal and distal control of the aorta and opening of the sac, you can see now the proximal opening and both renals inside the aneurysm sac. This was repaired by a Dacron graft. It was a 16 millimeter Dacron tube graft, quite larger than the size of the child, and this was intentional this time to try to make it a definite procedure. And proximal anastomosis was performed at the level of the celiac trunk, including the celiac trunk. You can see in the image on the left side with the yellow sling, and distal anastomosis to the aorta just above the renals, and the graft diameter was quite larger than the aortic diameter. Not only that, extra length was achieved by creating a small anterior curvature, so to make it like a Bombay, so you can accommodate the length of the child and the growth later on. Smooth first post-operative day with the polyuria, but on the second post-operative day there was anuria, vomiting once, but still hemodynamically stable. Hemoglobin dropped for just 1 gram, and intestinal sounds were audible. Together with our nephrologist, we diagnosed this as acute tubular necrosis, and it responded well to proper fluid balance and went fine later on. We published a series of patients in pediatric aneurysms in 2015 in the Annals of Pediatric Surgery. The challenge was always in the grafts. We used great saphenous veins, superficial femoral veins. We used the synthetic grafts whenever this was suitable. We used cryopreserved bovine grafts in one of the thoracic aneurysms, but we didn't use tissue-engineered grafts. And our conclusion was that management is usually individual and tailored to each case. Finding the suitable conduit is a challenge, and autogenous veins are preferred whenever available. Regarding trauma, blunt and penetrating trauma are rare, most commonly road traffic accidents, and they follow the same rules as in adults. But what is more common and actually increasing in frequency nowadays are the iatrogenic injuries, whether during open surgery or the more commonly performed now endovascular procedures. I've seen so many PDA devices that have fallen inside the aortic bifurcation, and even other devices. And these are managed either by open surgical repair or by a hybrid procedure where you try to snare the fallen object and bring it to an accessible artery where you can make an arteriotomy and then extract it safely without making much of a damage. Acute ischemia is very rare in children and usually reflects the presence of a hypercoagulable state or at least sepsis, and or maybe peripheral hypoperfusion, or secondary to peripheral vascular cannulation. Anticoagulation is the mainstay of treatment, and lytic therapy is actually very beneficial in the children. Even lytic therapy alone saves lots of limbs in the children. Open surgery is reserved to kids at a bigger age, and whenever the size of the vessel can be reconstructable. So my take-home message is that pediatric vascular surgery rules have to be followed whenever you face such a patient. Blood loss is fatal. Kids do not tolerate any blood loss. Conduit choice and sizing are the main challenge, and whenever you can use interrupted sutures to allow for growth of the grafts, and choose the appropriate time for intervention. Whenever you can postpone the reconstruction, please do, at least for the age of 8 to 10 years, so that you can make something that can be a little bit definite. Choose the appropriate exposure. You will be amazed how a finished steel incision in a small kid can be very exploratory and shows you the whole of the aorta, starting from the renals to the external iliac arteries. At the end, unfortunately, treatment has to be individualized. I cannot give an algorithm like the previous presentation to tell everyone what to do in every patient. Thank you.